Good afternoon. It is my honor to welcome you to the first ever Joel S. Levine, MD, Health Policy Lecture at Downstate Health Sciences University. This is a very special day in that Dr. Levine is one of our most distinguished graduates. And it's very special because I knew Dr. Levine from early in my medical training. I first met him in 1994 when I was a young resident at Baylor College of Medicine in internal medicine, and I had been elected to the National Resident Council of the American College of Physicians. And Dr. Levine was chair of the Board of Regents at that time, which is the Board of Trustees for the ACP. And he was a wonderful man who I always learned from in terms of his passion for patient care, his passion for community, his passion and love for his family, and his passion for doing the right thing in healthcare. Joel was very passionate about that. And one of the most impressive things about his career is that he pivoted away from pure clinical medicine to go work in the United States Senate for Senator Max Baucus. And Senator Baucus, history reminds us, was chair of the Senate Finance Committee when President Barack H. Obama was elected. And the work that Joel did with Senator Baucus led directly to the Patient Protection and Affordable Care Act, otherwise known as Obamacare. That much of the work that he did on Senator Baucus' staff got into the final Obamacare bill, which I believe tomorrow is the 12th anniversary of the passage of the Affordable Care Act. And I still remember when it was done through budget reconciliation. You know, there was a lot of churn at the White House about health care reform. I remember going to the White House, Mandy. Then I was president of Mary Medical College, and some leaders were called to the White House for us to give input to the president's team about the Affordable Care Act. And I just remember those days vividly trying to agitate for it. The ACP, again, American College of Physicians, a little later than that, I became the 101st president of the American College of Physicians. And so we continued to try to build on the great work of Joel and Senator Baucus and President Obama in getting that landmark piece of legislation over the wire. So I'll tell you a story on Saturday, November 9th, 2019. Dr. Levine wrote me a message, and it was a mere 6 months or so after he was here at Carnegie Hall to receive an honorary degree from his alma mater, Downstate. And this is what he wrote to me on November 9th, 2015 at 1:05 p.m. by email. He said, "Wayne, I want to let you know personally that I have been diagnosed with cancer. I want you to know how much I have valued our interactions and our friendship over the years. What a pleasure it has been to follow your personal professional triumphs, and also to reiterate how much your kindness in awarding me the honorary degree and your heartfelt comments at the commencement were treasured by Frida and myself." He then went on to plant the seed for why we're here today. He further wrote, "Additionally, my more well-defined mortality tends to make one think about things differently. I was wondering whether Downstate has a need for an annual visiting lectureship focused on expanding access to care for the underserved, health policy, and/or increasing diversity in the physician workforce. If there is a need, I may be interested, if my estate can afford it, in providing an endowment for the support of such a lectureship." He further wrote somewhat humorously, "Academics are not provided the same remuneration as private gastroenterologists, but I've done okay. And more importantly, my children, and thus my grandchildren, have all done better, Dan, as it should be," he said, "and do not require my bequest. I hope Frida lives to 100, and then in parentheses he wrote, "I'm not sure she would agree, but we have always supported a variety of charitable causes and will continue to do so whether I am here or not." it would be helpful to know that this lectureship is of significant help, please let me know. With warmest personal regards and regrets if we do not see each other again, Joel. That was the message he wrote to me, and I've never forgotten it because it encapsulated the greatness of the man, his humor, his understanding about his mortality, but yet how his work could be furthered post his demise. And so, ladies and gentlemen, that's why we're here today. What you see on the screen here is, I think, one of a proud day in his life. The moment at Carnegie Hall where he was awarded the Doctor of Humane Letters, honoris causa, honorary degree from his alma mater. So it was very special to him. And like I said, it's just the unfortunate fate of life that just a few months later he wrote me that beautiful message about his wish and request that we honor today. So friends and colleagues at Downstate, we have a number of our students watching virtually. This is a great man that is worthy of emulation, our respect. But if he were here today, more importantly, his work and what the work of all of us should be who care deeply about the health of Americans, indeed the world, in terms of health policy and progress to make this a more just and gentle nation. So when we finally got the details worked out, we thought it was most appropriate that the first lecturer be Dr. Levine's niece, and that is Dr. Mandy Cohen, who just recently stepped down as the Secretary of Health for the state of North Carolina, where she led the great state of North Carolina's COVID response over the last 2 years. Mandy was clearly recognized as, if not the best state health officer in the country, near the best. She was just fantastic. She was called upon by other state colleagues from other states around the country to say, hey, Mandy, tell us how North Carolina handled this and handled that and so forth. She has a wonderful background. She's now moved on to a new endeavor in the private sector that I think she'll share with you. But she's going to put in context and to deliver this first lecture, on, again, relevant to what we need to be thinking about in this post-COVID era in terms of health care. So, but before I bring Fred up, I want to have Joel's family to rise and to be recognized. We have his son, his sister, his brother-in-law, and more importantly, his lovely and passionate life partner for so many years, the Levine and extended family of Cohens. Please stand so that we could recognize you. Now, Mrs. Levine was just saying that they're both proud products of Brooklyn College. They met Brooklyn College, what, two subway stops down the line, I think one or two. She fondly remembered that they lived in the dormitories across the way when Dr. Levine was a medical student. And Susan, his sister, was one of the first, if not the first, nurse practitioner hired at Kings County. So great contributions. And son Dan is here, who's been very successful in his entrepreneurial and business activities. His brother-in-law, who has been an outstanding public school teacher and guidance counselor. And I thanked him for his service. God knows we need more good guidance counselors who believe in giving kids in public schools advice and counsel and recommendations. So thank you for what you did all those years, because I know Joel cared deeply about even that. So without further ado, it is my high honor to introduce to you our first ever Joel S. Levine, MD lecturer, his niece, the outstanding physician, public health official, scholar, Dr. Mandy Cohen. Mandy.
Well, good afternoon, Dr. Riley. Thank you so much for that kind introduction. And while we are moving on to hopefully my slides, I'll just take a minute to also acknowledge both my uncle, but really first my Aunt Frida, for her generosity in carrying out the wishes of my uncle, which was really to be able to bring to the student body here and the faculty an opportunity to hear from folks who are in the ring, if you will, trying to make the healthcare system work for everyone. And he felt really strongly that it not be purely a policy lecture. I think you heard in the email he wrote, he really wanted this to be about how are we going to change the system of healthcare and really to highlight what folks are doing to change how we think about access to care, about equity, and about making the system work for all, no matter what zip code you are born into. I've been very lucky to have had some opportunities to lead, not just at the state level in North Carolina, but before that for 7 years at the federal level. So I've had a lot of opportunity in the public sector space, and honestly, that comes from, and the reason why I served for so long in government is because of my family and the values that were instilled in us. About the fact that we are going to leave this world a better place. So I want to thank my Aunt Frida, my cousin Dan, who is here, and of course my parents, my mom Susan, as you heard, one of the very first nurse practitioners, pioneer in her field right here across the street, and my father as well. So I hope you enjoy this first lecture. I want to just say a couple more words about my Uncle Joel and what he was able to accomplish. I think if you look at the shape of health policy, one of the things that you should know about my uncle is the fact that everyone can get a screening colonoscopy covered by your insurance with no copay. That is a direct result of Dr. Joel Levine. Incredible how many people's lives have been saved by screening colonoscopies because of his effort, right? You have to set the context and the rules of the road to enable that kind of work to happen. But he also knew that it wasn't enough to just say, we're gonna cover it and we're gonna make it with no copay, right? Because there were so many more things involved in making access possible, but it certainly started with that government context. So he mid-career moved his family back from Denver all the way to Washington, D.C. to say, I'm going to take a year to make sure that physician voices were heard at the highest level of government, and that was the work that he was able to do. But one of the things I think that I am most proud of is not only that he changed the way we think about some structures in health policy, but he left his university job, prestigious job at the university in Denver, and went to the safety net hospital for the last decade of his career because he said, I can do more. I need to do more. And again, he had spent all this time in the academic space and certainly prestigious accomplishments there as a gastroenterologist, but said, I want to do more to think about how can we set up structures, and I want to go to the safety net hospital, Denver Health, in order to make change at this part of my career. So I admire his courage and his fortitude, but also he cared about equity before it was cool. Right now, which is great. I love seeing how equity is at the forefront of a lot of conversations, but he was talking about it and thinking about it from the very first moments. And that is really because he truly believed that he would have not had the opportunity in his life if not for downstate, if not for the opportunity to be able to access education, for, we're an immigrant family with no money, living right down the street here, that this was the opportunity to move forward, and he wants that opportunity. He wants everyone to have those opportunities to go forward. So I'm super honored to be here, to be able to honor him and his legacy, as well as share a bit about what I've been working on in North Carolina to honor his life and his legacy. So what I'm going to be talking about is a bit about my work in North Carolina leading through the COVID crisis. As Dr. Riley mentioned, I've been the Secretary of North Carolina's Health and Human Services. I was there a total of 5 years, the last 2 years through COVID, and it was certainly treacherous waters. I love this photo because you're trying to make sure that you're making it through the sea and the treacherous sea of COVID down there. And that's me at the head of the boat, trying to look forward and lead everyone. I'm wearing a mask. And you know, the leading in a crisis is a big challenge and for everyone. So I'm hoping as I talk about this, you'll not say, well, I hope you will see lessons in this for any sort of leadership challenge, and there are so many, right? We've been through COVID, but gosh, we have so many challenging issues we need to solve in healthcare, and some, I hope, gives you a little bit of a rubric for this. Probably the biggest takeaway for me in a leadership perspective is about how to build trust, because I really do believe trust was that foundation. It's the boat, if you will, that helped us make it through these challenging waters of COVID. But trust is incredibly valuable, but fragile. It takes years to build, seconds to break, and forever to repair. And as I was thinking about leading with an equity lens through this crisis, and I like the lens because she's looking with her out into the sea, making sure you could see over the horizon some issues. Sometimes when you move into a crisis, you think, well, I can't do anything new and hard as I go into a crisis, right? This is the time to go back to basics. But actually, I want to encourage everyone as you move into a crisis, it's exactly the time where we have to think differently. We have to do more around trust building in order to be able to create the response to a crisis that you want. So I hope you'll see that in what we'll go through in the next little bit. Let me tell you a little bit about North Carolina as I jump in, because any good leader in a crisis really is only as good as preparation. What do you have going into that crisis? So North Carolina had some very good assets, but frankly, we also had a couple of really challenging things, and frankly, I'd call black eyes as we went into the crisis. We are a very large state and growing. We're the 9th largest state, and we are purple in terms of our politics, meaning I worked for a Democratic governor, but our legislature was not just dominated by Republicans, it was a supermajority, meaning they could override a veto of a Republican. So it was a lot of dividedness within our state. We're an incredibly rural state, given our size, and that's why I put urban in quotes. Like, there is nothing like a New York City or Brooklyn, like anywhere in North Carolina. Even if they tell you there's a city, they are wrong, as a New Yorker. But it is also incredibly racially diverse. So 24% of the state is African American, 9% Hispanic, 2% American Indians. We have a number of federally recognized tribes. And I think that is absolutely an asset, but I think it makes us a picture of what the country is, what the country in the United States is as a whole. And I thought about that a lot as I led through the COVID crisis, about all the challenges we were having across the country. We also had an incredibly decentralized public health structure, but we had some things that we were doing in North Carolina that I was very proud of as we led into the crisis, which I think really helped us to respond. But the black eye that we didn't have is we have not expanded Medicaid. So we have a pretty high uninsured rate in North Carolina, exactly the kind of thing my uncle would really be fighting for, which would be Medicaid expansion, something we did not have, unfortunately, and that was frankly a result of the politics of the state. But we had made some really good investments that I was very proud of. One was ahead of COVID, we had already established an effort to create a way to link together the healthcare system and all of the human services and the community organizations across the state. We called that platform NC Care 360. It was a way that embeds in your EHR, so if you are referring, just like you would refer to a cardiologist, you could actually refer to a food bank or a housing support or to employment services, and you'd actually get a closed loop referral. We were the first state in the country to do this and take it statewide. Really proud of this infrastructure, and I'll come back to it later because I think it was really important. We'd also already gotten permission from the federal government to use our Medicaid dollars differently, to say, I don't want to just spend it on medical care. Again, I'm a physician, so I think that's always going to be important, but we knew that you needed to spend your dollars on certain things like stable housing, on food security, on transportation, if you were actually going to get health. So we had those things in the background in North Carolina going into the crisis, which I really think helped us, even if we went in with one hand tied behind our back in terms of, did people actually have an insurance card in their wallet? Okay, so there are really three tenets of that trust building that I'm going to go through around equity that I think were really important. So we had some preparation, but the first really big thing that I learned in leading through the crisis, and it's probably pretty obvious, but if you want to build trust, you need to be transparent. And I also think this is one of the hardest things to do as a leader, because sometimes when you're transparent, it means you're also showing where you're weakest, where are things going wrong the most. And particularly when you think about an equity context, we already know that things are not equitable, right? And so you have the data will just, often if you are measuring it accurately, it will show that. And that means showing where things are not going well is really hard, particularly in a political context. Everyone wants to seem like they've got it all together and all in hand all the time. But that's not reality, and I think folks know it. And if you're not being transparent, you can't build trust with folks. So we took in North Carolina the tack to say, we are going to be transparent with all of our data. We're going to be incredibly focused on getting good data, even if that means we're going to be showing where we are not doing a good job. And it did show that at the beginning. So for us, data was the oxygen that powered our response. We won all sorts of awards for data transparency, and you will see data in itself does nothing. It just identifies the problems, but you can't solve problems you don't see. So it was really important to us to put a premium on that. So for example, by the time we got to our vaccine efforts in COVID, we said this is so important to us. We've learned through testing and contact tracing and hospitalizations. The data wasn't very good. We didn't get the race and ethnicity data we wanted through all of that because of legacy programs. All right, vaccine, this is new. We're going to do something new and different. And so as part of that, we created our own vaccine data management system. We did not use the federal government's one. We created our own because we wanted the control to say, this is so important to us that we collect this data well. We want to control it ourselves, and we want to require race and ethnicity as part of this. So in order to give a vaccine in North Carolina, you must record race and ethnicity data. And what that means, and you got to get into the details here, is you can't say unknown. That's not a valid answer in North Carolina, because unfortunately that is a shorthand for not asking, and that was not important to us. So we have 99.9% of all data collected in race and ethnicity, and that was really important to us because we used it every day. The way we used it every day was to say, I'm going to look at that data, look at that dashboard, and change where we are going to put resources. I'm going to change how much vaccine goes to which communities. I'm going to decide how much money I can give to do supportive vaccine events, on incentives, depending on that data. So it wasn't data for data's sake. It was using it to change how we would actually do our work. So you see, we use that data to decide to give more vaccine, again, to underserved communities, or to give, like I said, more incentives. And it worked. We didn't, but I will say, we didn't start off well. As I said, if you use any of this data, you're going to see equity gaps at first, and that is what we saw here. We definitely saw less vaccinations happening in our African American community and our Hispanic community. But using that data, we definitely changed what we did in North Carolina, and as we sit here right now, for example, our Hispanic community is out-vaccinated our white communities in North Carolina, which is tremendous. I think we are only one of 3 states in which that has happened. So a higher percentage of those who are Hispanic Latinx are vaccinated in North Carolina than if you are white. And in the African American community, we got to nearly on par across every age group. So they didn't surpass in the African American community, but at least we got to equitable, which is a huge accomplishment, and we're really proud of doing that. So embracing transparency was hard because at first it was very clear where we were falling short. But we used that data to drive our work and get better. So transparency, data, really important. All right. The second lesson learned around how you think about equity in a crisis is about proactively communicating. And I'll say the folks in North Carolina saw lots of this of me, which is standing at a podium like this and talking. And some might think that that's communicating. It's one part of it, it is. But the listening is actually probably the most important part of the proactively communicating if you were thinking about equity. And it was very, very important to me. So yes, it was talking so folks could know what you're doing. We could all be on the same page. You're building trust. But it was the listening that was so critical as we proactively communicated because we needed to build trust. So for us, we, right at the beginning of the pandemic, set up a group that advised us on equity issues. We called it the Historically Marginalized Population Working Group. It was quite large. At first, we didn't know exactly how to take everyone's input and channel it into ways that felt like we were helping the community each and every day. But we got into this place where we were really co-creating solutions with the community. They felt very empowered by it, and so did we. We felt like we got a lot more out of our messaging campaigns and all of the work that we did to try to connect with communities because we had folks at the front end working with us. But what we realized quickly is that you couldn't continue to just lean on community organizations that were the trusted members of their community without actually resourcing them, paying them. Like, this is their time, this is their livelihood. You have to pay people for their time and their talent. And so we had to also establish a program called Healthier Together to recognize that we needed to actually resource folks to do the work of building trust, of talking about vaccines, about talking about COVID and why masks are important or what have you. So it was really important for us, again, to build that together, and we used different organizations to make sure we're supporting that on the ground work. The other part, again, with building together was the talking. I did do a lot of press conferences, many, many, many press conferences, more than 150 of them within 18 months, so that was a lot. But what we did was we made sure each one of them obviously was simulcast in Spanish, and we'd often do a second press conference right after the first, all geared in Spanish. So we do the entire press conference, not just simulcast in Spanish, but with with Spanish speaking physicians and public health leaders so that they could hear directly from leaders within their own community. And that really paid off as we went forward. And we also invested a lot of time in market research, again, the listening. What do we need to know about our communities? And so what came from that were certain campaigns like this one, where we wanted folks to see themselves represented in something like wearing a mask. So we had a whatever your reason mask campaign. And so people wear masks for different reasons. They want to protect their family, or they're wearing it because they have an underlying medical condition, or they care about their friends. So this one's really resonated in North Carolina. We won multiple awards for this, but the awards are not the issue. The issue was getting the cohesion of everyone seeing themselves in this collective effort. So we were really proud of that work. And then the other part of proactive communication is showing up, is just being present, and I did a lot of that. And I was able to connect with a lot of important community leaders throughout the work to make sure that that my showing up was critical. The governor showing up with me to make sure that they knew that they could trust us, that we were in this together. At the top here, you'll see that you may recognize that as Reverend Barber, who is an amazing civil rights leader from North Carolina, leads the Poor People's Campaign, and he was generous enough that he and I got vaccinated together. We both got the Johnson & Johnson vaccine together on television, and that was really important. So we had this overlap, both civil rights, the religious community, the medical community sort of coming together. There's another picture of me. I did a lot of charts and graphs, like again, just trying to be as transparent as we can on TV. Obviously during COVID, getting physically together was hard, but so we did a lot on Zoom wherever we could, but you can also see down, I spent a lot of time with our community health workers, which I'll talk about in a second, that really both help folks feel comfortable at vaccine events and did a lot of the hard work of building those important relationships. So showing up to build trust is so important as part of communication. And then the last, so if we had transparency and great data, you had proactive communication and building relationships. The last is around details. Because you can have good data, you can have these good relationships, but you gotta still point the ship and get into the details to make the execution happen and make it real in people's lives. And I'm the kind of leader, I'm a very practical, pragmatic, like how is this helping a person today? I think I channeled that very much from Joel. Very practical, like how is this going to help someone today? So you gotta get into the details. So for us, this is how some of those details took shape. We recognize that health is so much more than just access to a COVID test or even access to a vaccine. We know we had to surround communities, surround families, individuals with support. And so one of the ways we did that was developing what we called a support services program, using community health workers to say, if you tested positive to COVID, that we would actually help you get through it. A lot of the reason folks didn't want to get tested was because they knew if they were positive, they'd have to stay home from work. And if you're not at work, you're not making money. That means you're not making rent and putting food on the table. So we needed to say, no, we hear you. If you get positive, we'll both help you find a place to safely isolate. We will do wage replacement for you. We will pay you to stay out of work, and we'll help you with food, medicine, transportation. Now, we were able to do this for two reasons. One, there was a lot of COVID dollars that we were able to get access to, and we decided as a state that this was important for us to invest in. But we had that infrastructure before we went into COVID that we could take advantage of. We had a platform where we could track all of this with NC Care 360. We had a community health worker program. We knew how to pay for these things and sort of make this possible. So this is one real benefit. And by doing that, we were able to really not only keep folks well and not get COVID, we were able to certainly help those who were impacted. You can see in the last bullet, I mentioned that when we evaluated this in the counties that we went to, and again, we went to counties with higher percentages of the community that were African American or Hispanic or American Indian, and we saw about a 12 to 15% less COVID in those counties once we were running these programs. So you would think it was just supporting those who got sick, but what it was really doing was helping us to prevent further spread within the communities. And so it was a really successful, and actually we are talking right now, well, I'm not with the state anymore, but the state is talking right now with FEMA, the CDC and others, how do we take this and make this standard practice when we respond to any kind of communicable disease outbreak, hurricane, or what have you, that this is sort of the standard of what we do, which is these wraparound support kinds of programs. In addition, we did things like huge nutrition investments. And I will say, this is where every state could have done this, but only 5 did. And one of them was North Carolina, and I'd never really, I asked myself, why didn't more states do this? But for example, we were able to take advantage of a federal program to pull down more federal resources for food support for families with children. I think you all know that kids get free and reduced lunch and breakfast at school. When they closed the schools, we were very worried about our nutrition availability for our students and our families. And the federal government had this program to say, yeah, we'll let you give more, actual just cash for groceries to those families. But there were hoops to jump through, as always. You have to do some real work to get this done. But we prioritized this, and we were able to get an extra $1.7 billion for families in North Carolina over the COVID crisis. That's real money. That's real money, not just for the families who were buying food for their families, but for our businesses too. This was a huge economic generator in a number of our communities at times where things were really tight. So those are the ways in which we try to both raise up public health, but also think about economic health at the same time in doing these work. Similar on the child care investments, I'm sure it was a huge strain for families who are all essential workers who are here at Kings County or here at Downstate trying to stay at work but still need childcare. We spent a lot of time and resources making sure that childcare was available. So those are the kinds of things we did in terms of making the reality possible. Yes, a lot of time spent on testing and contact tracing, and I'm sure there's others who can give you lots of great lectures on this, but what we tried to do was think beyond that to these other pieces, the nutrition, the childcare, and things like the wraparound supports in order to support folks through the COVID crisis. So that's the essence of the lessons that I wanted to share about leading through equity. So a couple lessons learned. Again, advancing health equity. I thought I was a leader that led with equity before the COVID crisis, and I will share that I was not. I am such a different leader coming out of the COVID crisis than when I went into it. I think before, I had folks on my team who I assigned. You think about equity for our work, and then you sort of move on with your day. That is not leading with equity, unfortunately. You as the leader have to own it and drive it every day and make it part of what you are doing, and it requires a lot of consistent effort and prioritization, because there's a lot to prioritize in a crisis, and it's easy for that to fall down the list of priorities, but you have to put it up at the top over and over every single day. You cannot delegate it to someone else on your team. That is what changed for me as a leader as we went forward through COVID, and would encourage those of you who think about this, about how you can prioritize that for your work. So the second takeaway was measuring race and ethnicity was the absolute minimum. Now, we spent a lot of time on that measurement, and frankly, we are so bad at it if you look at us across healthcare about how much unknown there is in the space. So we should, rightly so, spend more time thinking about measuring race and ethnicity, but honestly, it is like the bare minimum of what we should be doing, because what's so important about it is, what are you going to do with the data, right? What are you going to do to actionably change how you move through the world because you have that data? And if you're not creating an organization that is a learning organization that uses data, you have to be doing both, not just measuring it. The relationship building, I think I mentioned a few times here, is so critical, and so much of this is about showing up. And that was hard to do in COVID, but thinking about how do you engage the community, you have to really be there in person, look folks in the eye, and listen are so critical. I also want to really make the pitch that if you are going to do this work, to engage with the community, that is real work. And oftentimes we are leaning on really financially strapped organizations that are trying to do a lot with very little. And we, in healthcare, we have a lot of resources, and we need to make sure that we are thinking about that, and as we think about all sides of making a program successful, that we really have to resource the community organizations to be able to partner well with us in the healthcare system. Another is on leadership communication. I think this is something that hit home for me over and over as I tried to stand at a podium, and the governor and I tried to find the right words to lead us through a really hard crisis. Certainly we needed transparency, as I mentioned, but simplicity was also really important. Repetitive messages where folks could really understand what is the one thing you need me to remember from this 1-hour press conference. What is the one thing you need me to do? What is that simplicity? And then lastly, the humility. And what I mean by this is, man, this virus has changed, and we've learned a lot, and we had to watch the scientific process play out in real time, which is new for everybody. But if you approached it with a humility that I don't know all the answers as I stand here right today, this is what I know right now. I think if we talked a little less in absolutes, like we never have to wear masks again, or we always have to wear masks, or we always, or if we talk a little bit with more humility, I think that will build trust. I think folks understand that things change, and that they may have to change and move with them, but it's when we play our hand, if you will, and we don't approach it with humility, that I think it breaks down trust, and it allows that misinformation to grab hold. And they start to see, well, you said over there that we would never have to do this again. And those are the places where the misinformation and the distrust really comes to play. So approaching things with transparency, simplicity, and humility are really key. And then lastly, the whole person care really matters. We in healthcare sometimes get so fixated on our solutions in our space. And we gotta make sure that we remember that health is way bigger than what happens in the four walls of where we work. Health is really about what is happening to folks in their communities, and that when we craft health solutions, we can't do it alone from healthcare. We're always going to need to partner, and so thinking about how do you do that, that is something I very much learned from my uncle, and how do we think about those systems of care that are not going to be exclusively healthcare oriented if we really want to help our communities. So those are my takeaways from an equity lens around COVID. Just two more things to share, and this is really first, just a little more. You heard about the professional side of Joel Levine. Let me just share a little more about the family man, Joel Levine. And yes, I am strong enough to say, like, yes, that is me. That's me with those glasses, and that, yes, that's right. And so this is some family photos. Joel, Frida, and their family lived in Denver. I grew up here in New York. And, when you're in different parts of the country, the times that you come together are even more special. And so these are some of our family times together. And there's both my grandfather Mike and Grandma Sophie. And this was one of the last times that I got to spend with Joel before his passing. Actually, it was weeks before the COVID crisis hit. And I was so grateful that I was able to bring my daughters out to Denver and spend time with the family. We miss Joel very much. We miss him very much. He was incredible in his professional life, but just know he was just as incredible in his personal life. And I'm so grateful that Downstate can host this lecture on an ongoing basis here, I think both to learn from his professional mentorship about thinking about access, thinking about equity, but also the humility, I think was brought up a lot of times. And if you want to lead, it's so important to lead with that humility. And so I think he brought that as brilliant as he was. We always learn something from every dinner conversation with my Uncle Joel. So we miss him a lot, and I'm grateful that we're able to have this memory each and every year, and hopefully a place where folks can learn going forward. So thank you for having me. It's been a pleasure.
Outstanding. You can see why Dr. Levine was so proud of his niece, and why she was so recognized as one of the most innovative leaders over the last 2 years because of her work in North Carolina. And I had forgotten to mention, I'm glad you did, that you worked in the Obama administration as well, Mandy. I'd forgotten that. So, tremendous background. Thank you. You've done your uncle a wonderful honor by being the first lecturer, so it was fantastic. We have time for 2 or 3 questions, and I'll throw out the first one. I've been at a couple meetings, here in New York City. Mandy, Mayor Adams appointed me to the New York City. I'm one of the co-chairs of the New York City Recovery Task Force for the whole city. And, we've been having similar conversations to what you've mentioned there. And one of the things that I keep trying to stress whenever we have, meetings of the task force with the mayor and his team is, look, there is no Brooklyn COVID, there's no Queens COVID, there's no Bronx COVID. And in your world, back in North Carolina, you had to work with your Republican boss, a Democratic boss, Governor Cooper, but you also had two tough houses of the North Carolina legislature that were controlled exclusively by Republican elected officials. And so how did you navigate that difficult, choppy water of dealing with Republicans who didn't like some of the things you were telling the state of North Carolina citizens to do, such as wearing a mask, get vaccinated, et cetera? They probably didn't, some of them didn't like that you took your shot on TV with Reverend Barber, who is just an outstanding civil rights leader. I've met Reverend Barber and admired his work in terms of not just COVID, but just economic justice in North Carolina and around the country. But tell us how you navigated the politics, and then we'll take maybe two questions.
Sure. One of the things that I learned from mentors before I went to North Carolina was that, everyone's just a person and everything's about relationships. And this is, I learned from Sylvia Burwell, who was the Secretary of Health for President Obama. And she was incredible at building relationships across the aisle. We'd be in a meeting and an alert would come on her phone and be like, it's so-and-so's birthday today, or so-and-so's wife's birthday, and she knew everyone's kids and across, and at first she tried to know everyone as a human being, and that's what I tried to do when I first arrived in North Carolina. I wasn't from there, I'm from New York. I worked on Obamacare. Gosh, how was I gonna build bridges with folks? But luckily, before COVID came, I had 3 years to do that, and I think that was a really important time where I built a lot of bridges. We worked together on a lot of shared issues. We actually worked, one of the things I think brought us together across North Carolina was actually working on the opioid crisis, something that was really hard hit across the nation, but particularly in North Carolina. And folks, it was an issue that brought us all together, and I was able to help folks see that no matter where they sat along the political spectrum, they had a role to play in helping to solve the crisis. And we actually made a ton of headway, but I also think it built some trusted relationships as we went into crisis. And while we didn't always agree, there was a respect. And I think that respect started with my boss, the governor, who I will say as a politician is the best listener I have ever encountered. And so I think he set the tone for that listening posture. Didn't mean we always agreed, right? There were definitely disagreements, but the respect was there, and I think that changed the discourse and the dialogue from the beginning. And I think you didn't see the kinds of incredible vitriol that you saw in other places in the country. In North Carolina, sure, we had our share of no masks or what have you, but it really wasn't at the same intensity that I saw in other places. And I think because it started with that respect. And probably one of my more proud moments was the last time I went in front of the last oversight committee hearing. We're just talking about state budgets. My last time in front of the General Assembly, telling them, and them questioning me, why didn't you do this? Why did you do that? At the end of that, chaired by the Republicans, I got a standing ovation from the Republican and Democratic members of that, because I think that they recognize we really worked so hard to try to bridge divides. And again, I think it started with relationships.
Yeah, that's great. Thank you for sharing that. Question? Yes, sir.
Thank you, for the excellent service you have been providing. I have a comment and a question. The comment is, several years ago in our HIV clinic, we used to have a lot of people from North Carolina. And I asked one of the patients who migrated after the diagnosis of HIV. So I was curious. I asked him, when you migrated to New York? He said, you must be kidding. If I stayed in North Carolina, I would be dead by now. And
Great question. First, I would say we're still working on Medicaid, and even though I have left the government, I have not left that issue behind, and I actually still think that there is a window of opportunity because of the relationship building through COVID that may still happen in North Carolina. But the way we were able to help folks who did not have access to insurance coverage was to really use our COVID dollars from the federal government that had to fill those holes, and we used them pretty directly, whether it was creating these support programs where maybe I couldn't pay for all of the medical things through our COVID dollars, we could use the support programs around it. Certainly we could pay for testing and the vaccines were free and what have you. I was actually quite disappointed in the way the federal government set up the uninsured pot of money to help folks get things paid for. I would have done it very differently. And so I don't think those were actually accessed as much as they should have been from North Carolina. And because we saw that it was going to be such an administrative burden and basically not accessed, we almost recreated, we were able to create a pool of dollars to help with uncompensated care for our hospital systems, for our other large providers, in order to help them through this. So we used our own COVID dollars. But those are COVID dollars that I could have used for something else if we had Medicaid expansion. But we were able to have that flexibility to plug some of those holes with the COVID relief dollars that came from the federal government.
Question. Great. Yes.
Great.
Our Grassroots Institute.
Terrific.
So I really appreciated your presentation and wanted to think about how you make equity sustainable. So a lot of the things that you had talked about came as a result of the pandemic, and social determinants of health really became something that was recognized. A lot of those folks who needed that care, needed that additional support, needed it before
Yep.
the pandemic. And so how do you ensure that the system remains accountable for sustaining
Yeah.
and that lens is always there?
Yeah, what a fantastic question. I mean, the short version is it takes prioritization and leadership, number one, and then it takes sustainable funding, but it takes the creativity, often at the state and local level, to make sure that you are taking advantage of those streams of funding to make things sustainable. So you saw that there is some work that we did prior to COVID, and we were able to access dollars in different ways and think creatively about that. I will say that I spent a lot of time mobilizing our philanthropic community in North Carolina around a shared goal. They were giving lots of money, I think, to important things, but it wasn't cohesive. It didn't have a shared prioritization amongst it. And so actually I spent a lot of time as a state leader helping philanthropy to see a unified way for them to sustain some of the equity, or frankly to start the equity work, and then use some of the government programs to then look at a sustainability pathway. I think that there are a lot of really great government programs that can be used in a much more equitable way if we had some front-end ways to make them more accessible, right? Here's a great example in North Carolina. Our Medicaid program covers a lot of moms, young moms who are either pregnant or just had a baby, and they are also eligible for WIC. So they're eligible for things like food, groceries, or diapers, or formula, what have you. And we know that they are eligible for it, but only about 30% of moms actually take advantage of it. And it's not because they don't need help with free diapers, it's because the program was so complex and it required an in-person visit every 30 days. Why is that necessary? And I will just say, as a new mom, the last thing I could think about was like getting my newborn into a car to go to some random, state office. So we completely revamped how we do, WIC assessments, and we essentially now, if you are eligible for Medicaid, you're automatically eligible for WIC. We've completely changed how we do that. So I think there are ways, the longer version of the answer, there are ways to access resources. You got to be clever about it. You got to be creative, but to sustain equity in investments and driving towards health. But it has to start at the top with leaders who are willing to prioritize that. and make some of those data and technology investments to facilitate things, and then also building that trust with the community at the same time. So again, I think it really does take it all hands on deck, but I do think that there is some sustainable funding that we aren't taking advantage of, that if we have the right leadership, we absolutely could.
One more. Last question? Going once, going twice? All right, great.
Okay.
Let's give Dr. Cohen a wonderful round of applause. Let me close out. Well, again, colleagues, thank you for coming to honor this great man, a distinguished son of downstate who went out with his downstate degree and changed communities, and I would argue the world. And we honor the memory, the work of Joel S. Levine, MD. We're delighted that the Cohen and Levine family can be here to see one of their progeny continue his great work. And so it's incumbent upon us here at Downstate to continue all of this, which we do on a daily basis so well. So again, thank you very much. What a great way to start this lecture. Dr. Cohen, thank you so much for your wonderful, thank you very much. We'll take some pictures. We get everybody out. Take pictures. Marco, we'll take some pictures now. Come on. Frida, we'll take some pictures. Would you like it? Oh,
that off.
no, you want, yeah, put your title slide up first.
Like, you don't need me in the,
There we go.
oh, you want that one?
Yeah, that one.
Or you want this one? Okay, that one.